Well, I thank Chris and Kristen and Parveen for giving me the opportunity to speak on this subject, which I'm rather passionate about, and I'll try not to repeat what you've just heard. With regard to disclosure of conflicts of interest, I am the PI of an investigator-initiated study sponsored by Merck, whose purpose is to increase the use of the vaccine against Zoster at NYU and Bellevue in accordance with current national recommendations, and I work strictly as a volunteer. So as we are aware, chickenpox is the primary infection and Zoster is the recurrence. We get shingles from our own chickenpox and not from someone else. Vaccine against chickenpox has been available in the United States since 1995, and in ophthalmic literature, there's talk about the increase in Zoster being due to less exposure of adults to chickenpox. But there is some concrete evidence against this insofar as the Zoster incidence began to go up before chickenpox vaccination became widespread. And in addition, incidence of Zoster does not vary by state varicella chickenpox vaccine coverage. And these reports from the CDC in the U.S. are also reflected in reports from other countries. So there's a consensus that Zoster is associated with increased age and decreased cell-mediated immunity, and it's really important to emphasize how common a disease it is, with 1 million new cases per year in the U.S. And while it is much more common and more severe in immunocompromised people, 1 in 4 immunocompetent people in the U.S. will get Zoster. So misconception number 1 is that healthy people are not at risk for Zoster, and it's potentially disabling sequela because we are. And looking at the age of onset of Zoster, there's a remarkable paper entitled Geriatric Herpes Zoster. It was published in 1971 and is often quoted regarding the incidence of postherpetic neuralgia. And it was striking to me that almost 60% of patients back then were under age 60 when they were diagnosed. So geriatricity is in the eyes of the beholder. A more recent study published by Merck scientists shows that while the rate does go up with age, the actual number of cases increase in the 40s and peaks age 50s to 70s. So misconception number 2 is that Zoster is only a disease of the elderly. It affects people in their prime too. And our experience at Wills, when we looked at the herpes zoster ophthalmicus cases, reflects exactly what was reported for Zoster in general, where we see a little beginning to increase in the 30s, more in the 40s, peaks in the 50s, and stays high 50s through 70s. And another disclosure is I'm one of those people in the 50s who got this disease. And although the vaccine is designed to prevent shingles and to prevent postherpetic neuralgia, we would also like to prevent the spectrum of corneal and other ocular and ophthalmic disease that comes with this devastating infection. The late corneal signs of Zoster are interesting. We used to call them Zoster pseudodendrites. The PC term now is dendriform keratitis. And we know now that they are PCR positive for varicella zoster virus. Debbie Pavin-Langston was the first to report this, and more recently, more cases have been described. So whereas in the past, lubrication was how we treated them, now we're more likely to use either oral antivirals or topical ganciclovir for short-term use. This is new evidence of chronic infection, and it's in stark contrast to our previous understanding of the disease. And chronic active infection also contributes to strokes and postherpetic neuralgia. And because of this understanding of the chronicity of the infection, my next big project is to spearhead a multicenter trial to look at chronic oral antiviral treatment similar to the HEADS APT trial to see if we can reduce complications of herpes zoster ophthalmicus with 1 year of prophylactic antivirals. Postherpetic neuralgia is defined as pain and itch or itch beyond 3 months. It increases with age and the severity of the acute episode, and it can be exceedingly debilitating. Misconceptions number 3 and 4 are that antiviral treatment of zoster prevents postherpetic neuralgia and that there is safe and effective treatment for postherpetic neuralgia. whereas in reality, to prevent postherpetic neuralgia, we need to prevent herpes zoster. First anecdote I found leafing through my reunion book written by someone who I don't know but who gives me permission to share. She wrote, "I went to visit my dad and was shocked to see him looking like a concentration camp survivor. His troubles began with a terrible attack of shingles that left him with awful pain and weakness. His doctors were convinced he had metastatic cancer. I went to help him, and month after month, instead of dying, he got better. Get your shingles shot. It ruined my father's life, turning him from an independent man able to take care of his disabled wife into someone who had to move into an assisted living facility." And I get more and more anecdotes to share every time I give a talk. And last year I spoke to a group of successful businessmen, and someone came up to me afterwards and said, "My dad had shingles approximately 11 years before he passed away. It was the beginning of the decline in his health. He began to have mini strokes, or TIAs, that increased over time." These were Zoster related, I'm sure. "I wish I had this information years ago. You gave everyone in that room a wonderful early holiday gift. I hope they choose to use it. What made it even more meaningful was sharing your own personal story." So as we're aware, there is a vaccine that is safe and effective in preventing zoster. And it is FDA approved and CDC recommended for immunocompetent patients age 60 plus. And in March of 2011, it was FDA approved for people age 50 plus. The contraindications are primarily immunocompromised by diseases affecting cell-mediated immunity as well as immunosuppressive treatment. The CDC website is an excellent source of information. Ophthalmologists should be aware that people receiving disease-modifying agents like infliximab and et cetera are not candidates for this vaccine. With regard to the prevention of herpes zoster, it is recommended for people who've had shingles. The Mayo Clinic reports a 6% recurrence rate of shingles in an 8-year period. It is also recommended for people without a history of chickenpox, since 99% of us age 40 plus have had chickenpox. The only significant side effects relate to injection site reactions. And in a study of 190,000 patients, these local allergic reactions were very rare and mild. And so if anyone is not getting the vaccine because they're not sure it's safe, you don't need to wait anymore. There is an association with efficacy and the age. The original New England Journal of Medicine article showed better efficacy in people in their 60s than 70s in preventing the actual infection. A larger population-based study out of Kaiser showed a 55% reduction in all ages. You might say, well, if I get the flu shot, I want 100% protection, but the reason it's lower for zoster is you're getting it from your own chickenpox, not from someone else. But in the most recent ZEST study, again, looking at people in their 50s, you have almost a 70% decrease in infection. So it appears better to get the vaccine in your 50s and 60s, but it's never too late to get it, since its effect on disease severity is greater in the older people. Usage of the vaccine is disappointing, and as of 2010, according to our latest publications from the CDC, less than 15% of Americans who should have it have received it, and the results are less than 5% of blacks and Hispanics. So why is the vaccine against zoster not used as recommended? There are a number of factors, including high cost, complex reimbursement, the requirement for frozen storage, production and availability issues that have been resolved. But surprisingly, the most important blockage is the lack of a strong physician recommendation. In one survey of general internists, while the vast majority recommended the vaccine, less than half strongly recommended, in contrast to their strong recommendation to flu and pneumovax. At NYU, we introduced a number of interventions to increase use of the vaccine, including education, increasing the supply at the pharmacy, even when it was in short supply, and having the option at the pharmacy for patients to get the vaccine with a prescription for their doctor administered by a nurse, as well as EPIC, electronic health record, health maintenance reminders with a link to the CDC website for additional information. These were all done last summer and fall. In our study, I've worked with people in ophthalmology and medicine and statistics, and in the ophthalmology part, we obtained written consent, screened patients in the Bellevue Eye Clinic, and had the nurse give the vaccine to 100 eligible and willing patients at no cost. And this enabled us to study non-cost and access barriers in an underserved population, as well as the role of ophthalmologists in increasing usage. The second part of the study involves a survey of the Division of Internal Medicine doctors at NYU regarding their knowledge, attitudes, and practices before and most recently 1 year after our interventions, and that is ongoing. I'd like to share with you the Bellevue results. This was done last winter. We had 100 patients who were screened and received the vaccine, and we compared them to 66 patients who were screened and eligible but declined the vaccine. Half of our patients were Hispanic and 20% were African American, but there was no difference in the acceptance of the vaccine by racial status. So the usage of the vaccine among minorities is not because they are against vaccines. When we asked our patients about previous vaccinations and medical care, the majority had had a flu shot the previous year, have a regular doctor who they had seen. So patients, even in our population, have primary care doctors with many missed opportunities to get vaccinated. We asked about attitudes, and the large majority of patients would get the vaccine if recommended by their doctor. What's interesting, a number of people didn't want it from us, and the most common reason was they wanted to hear from their primary care doctor. So in the Bellevue Eye Clinic, in a study setting, the recommendation of the primary care doctor about vaccinations is very important. However, I believe that ophthalmologists such as us, with stronger relationships with their patients, will be much more effective in encouraging them to get the Zoster vaccination. And I urge you to recommend the vaccine to your patients. Tell your immunocompetent patients to get it at their pharmacy. In the states of Pennsylvania and in New Jersey, you do not need a prescription. They can go to their pharmacy and get it. And if you're unsure about their eligibility, refer them to their PCP doctor. But I would like to see ophthalmologists encourage their patients to do it, since the PCP doctors aren't doing such a good job. And the results of the baseline study are in your handout, and for the sake of time, I will not include them here. What I would like to say, though, is that I think when you want to change practices and behavior, it takes a number of things. One is evidence. We know we have a vaccine that works. Two is making it easy. And I think by doing it at the pharmacy or having nurses be involved with recommending what patients need for their preventive care regimen, so it's sort of like an automatic thing, and doctors just need to opt out of it. We want to make it easy. But yesterday I heard Arthur Kaplan speak about how you get people to change behavior, and he was talking about getting nurses to be vaccinated against flu. And he said, you need to have the evidence, you need to make it easy, but even that's not enough. You also have to have an ethical sense that this is the right thing to do, that we ought to be vaccinated and we ought to recommend vaccination for our patients. Thank you.